these are data looking at frailty as a predictor. So if you have mild or moderate frailty, 80% of us will be alive at 1 year. But if you have severe frailty, 50% will be alive at 1 year. So frailty as an indicator of who is likely to need home-based services is a good predictor. Here's another predictor, the surprise question. This study was done in Catalonia, northern Spain, where every patient has their own primary care doctor. And they all have electronic health records, and they know who's on their panel. And these doctors were asked, on your entire panel, please identify the patients whom you would not be surprised if they died in the next year. That surprise question turns out to be a very accurate predictor of prognosis. It's not asking, is this person going to die, but would you be surprised? Which is another thing we should be putting in our electronic health record, because it's such a great predictor of need. So fascinating, these doctors were able to identify a bunch of patients whom they wouldn't be surprised if they died in the next year, and look at who the largest group was. Frailty and dementia. Not cancer, not heart failure, not stroke or liver, renal failure, but advanced frailty and dementia were those most likely in these doctors' views. If we assessed it, we could target services to these populations. So ask yourself, would you be surprised if this patient died in the next year or two? Does this patient have an advanced long-term condition or multiple long-term conditions or a new illness or both? Does this patient have functional impairment, unplanned weight loss, more than 2 admissions in the last year that were not elective, live in a nursing home or assisted living, have inadequate social supports, transportation, food, safe environment, or need more help at home? These are the 5% that need much more attention if they're to stay out of our ERs and hospitals. So the second characteristic is goal setting. One of the geriatricians who runs one of the care transition management programs in New Haven told me when they looked at which patients failed their care transition management program, it was always people who had not had a goals of care discussion, where the patient and family still thought that modern medicine was going to cure whatever was going on. So ask the person and their family, what is most important to you? It's such a simple question. It's almost never live forever. Have you ever had someone say that? You probably haven't asked this question very much, but what is most important to you? It's often getting to my granddaughter's high school graduation, living until my daughter has her 3rd baby, getting into my backyard to be with my garden, taking a vacation. It's not come back to the ED in the hospital more times. So a couple of geriatricians, friends of mine, wrote in the New England Journal last year, ultimately good medicine is about doing right for the patient. For patients with multiple conditions, severe disability, limited life expectancy, any accounting of how well we're doing and how well we're succeeding in providing care must above all consider patients' preferred outcomes. That means you gotta ask. This is a great study done in several hundred seniors in a senior center, so they were not, homebound in any way. They were able to get to the senior center. Asked to rank what was most important to them among remaining independent, relief from distressing symptoms, or living longer. So first was what? Independence. Second, not being subject to unbearable symptoms. Dead last. Living longer. How is our healthcare system built? The opposite. The opposite. It's supposed to be here to serve people's needs. We're not even asking. And, there are data. Some of it's contradictory, but some studies showing that people who do go through an advanced care planning process, who do have a discussion about what to expect in the future, including prognosis, tend to get much higher quality care and much lower cost care at the end of their life. So the third characteristic, remember, is that families are key. Why did Mr. B keep coming back to the ED? Because of Mrs. B. because Mrs. B was overwhelmed and couldn't handle the burden, right? So families deliver 40 billion hours of unpaid work, worth about $500 billion. They provide wound care, they administer medications, they give injections, things we would not let a certified nursing assistant do, that we would only let an RN do. We ask untrained, unlicensed family members to do every single day. And family members who provide care are at significantly increased risk of personal bankruptcy, of serious illness, and higher risk of death. So they cost the system a lot, even if there weren't a moral imperative to do better. So we need to help families. We've got to ask families, what do you need? What questions do you have? What supports do you need? And it's so simple and obvious, but we don't do it. We tell them what to do on discharge. Here's the third copy of an illegible carbon that tells you what to do. You know, no wonder people come back to the ED. And mobilizing community resources, Area Agency on Aging, Meals on Wheels, ambulance services. These are our job. We don't do this stuff, people will end up back in the ED. So the care coordination models have to provide 24/7 access. If Mrs. B had been able to talk to someone on the phone at 7 p.m. on a Thursday, who would have been able to mobilize someone to get to the house to help them, and get an elevated toilet seat with bars and a grab bar opposite the toilet to help Mr. B get up, that would have solved the problem. The relationships need to be consistent, not a different person from India who speaks with a heavy accent who's different every week. It's got to be Susie. Oh, Susie, somebody I know, somebody who knows me. It's got to focus on what we in medicine like to call the social and behavioral determinants of health, because the overwhelming majority of ill health and disease is socially determined. Poverty, language, being hungry, not having a safe place to live, not having heat. Yet the medical care system, that's not our problem. Yet we end up with those problems because as a society, we're not addressing them. And we need to integrate social service delivery with medical service delivery. So we don't want a separate team dealing with the poverty and the housing and the nutrition from the team that's dealing with the hypertension, diabetes, and dementia, because again, the family will just turn it off. It's just confusing. Too many people calling, too many people visiting. They need to be integrated. So who has figured this out? Because, frankly, it is in their financial best interest to do so. Who has the biggest stake, aside from patients and families, in staying out of the ER and the hospital? It's the payers, right? So you guys may not realize that 30% of Medicare beneficiaries are now in Medicare Advantage. A third, and the number is growing, in spite of the threats that it would go away when there were cuts in the amount of money they got from government. So that is commercially for-profit driven health systems that stand to make more money for their shareholders if they spend less money on Medicare beneficiaries. They're investing heavily in community-based palliative care because it's our patient population that will bankrupt them. And these are just a few of the examples of private insurers that are developing complex care management and palliative care models in the community. Have you guys heard of DaVita, a for-profit dialysis company? Do you have them here? So DaVita makes tons of margin. They just bought something called Healthcare Partners, which is a primary care house calls practice, primarily in California, but other Western states as well. They're now caring for more than 700,000 patients. And DaVita bought them because the margin under Medicare Advantage was 15%. Why? Because they were keeping people out of the hospital by taking care of them at home, meeting their needs. So there's all kinds of profit motivation here, and those who see profit are moving into this space because they recognize that it's perfectly obvious if you meet people's needs at home, They don't go to the hospital, and you save money. This is one of the few examples where you do well by doing good. So pain and symptoms. Mr. B did not have cancer. He didn't have a fracture. He had arthritis and low back pain. Now, it turns out that about half of older adults have significant pain in their last 6 months of life, and the vast majority of it is due to degenerative joint disease, arthritis, which we trivialize, minimize, and do not treat. And then people fall, and they come to the ED. And it's not only pain, there's a whole bunch of other symptoms that cause distress. And I didn't include the slide, but 90% of ED visits in people over age 65 are due to symptoms. Now, some of those symptoms might be from an MI, or pneumonia, or a pulmonary embolism, but a lot of them are like Mr. B. And guess what the other 10% are? The diagnostic category is accidents. What do you think those are? Right. Right. So it's absence of palliative care principles and practices in the community that lead to the vast majority of ED visits in the elderly. And then we talked about the need to change the dose. We need to be able to titrate dose intensity as we move on.